When evaluating a sudden neurological deficit on the ward, the baseline clinical reflex is nearly universal. We assume an older patient with vascular risk factors has suffered an acute arterial occlusion. In typical arterial ischemia, forward blood flow is halted instantly. The downstream capillary network is starved of oxygen, and dependent brain tissue suffers immediate infarction. But certain presentations break this clinical mold. Consider a young female patient arriving with a severe headache that has worsened progressively over days, accompanied by visual disturbances, rather than a sudden, pinpoint focal weakness. This points away from the arteries and toward the veins. The diagnosis is cerebral venous thrombosis, or CVT. Epidemiologically, the profile is entirely inverted from typical stroke patients. It predominantly affects young women at a 3-to-1 ratio. This demographic variance is driven by hypercoagulable states. The physiological demands of pregnancy, the immediate postpartum period, and oral contraceptive pills drastically increase the likelihood of venous clots forming in the skull. Diagnosing CVT requires discarding the arterial sudden onset mindset. To spot it, a clinician must evaluate the patient through the lens of a gradual systemic drainage failure driven by systemic hypercoagulability. The dural venous drainage system acts as the brain's exhaust network. After perfusing the cerebral tissue, blood collects in these large channels situated between the layers of the dura mater, eventually returning to the heart via the internal jugular vein. This network possesses one critical architectural feature that governs the entire pathology of CVT: the complete absence of valves. Blood relies entirely on pressure gradients to move. When a thrombus forms in this specific environment, forward venous drainage into the jugular system stops. Without one-way valves to protect the upstream vessels, mechanical pressure has nowhere to go but in reverse. Blood pools, radiating severe pressure backward into delicate capillary beds. This retrograde pressure creates a cascading physiological failure. Fluid leaks out into the surrounding brain tissue, causing widespread cerebral edema and a dangerous, compounding rise in intracranial pressure. Left unchecked, the walls of the microscopic vessels fail entirely. The resulting venous hypertension eventually causes the tissue to infarct and hemorrhage directly into the brain. Because fluid pressure builds uniformly backward in a system without valves, CVT presents primarily as an expanding pressure syndrome, marked by raised ICP, rather than an isolated patch of ischemia. We can trace this pressure logic directly to specific clinical syndromes, starting at the apex of the skull with the most common variant, superior sagittal sinus thrombosis. Because the superior sagittal sinus drains such a massive surface area of the brain, an occlusion here results directly in a massive, global increase in intracranial pressure. The patient will not typically present with a drooping face or a weak arm. They will present with the classic triad of raised ICP, a severe headache, persistent morning vomiting, and visual disturbances resulting from papilledema. As the engorged veins press against the surface of the brain, the resulting cortical irritation often triggers focal or generalized seizures. To confirm the clinical suspicion, a standard non-contrast scan is insufficient. The diagnostic test of choice is a contrast-enhanced CT scan. This CT scan displays the definitive evidence of sagittal sinus thrombosis, the empty delta sign. At the scan's bottom, white borders appear where contrast dye fills the collateral channels. The anomaly is the center. The thrombus fails to absorb dye, creating a dark, empty void. While the empty delta sign is highly specific and effectively guarantees the diagnosis, it only actually appears in roughly a quarter of all cases. When it is present, that dark central void is the exact visual manifestation of the venous occlusion restricting the brain's exhaust system. If we move from the apex down to the base of the skull, the clinical picture changes entirely. Here we find cavernous sinus thrombosis. Unlike the apex, where clots are usually driven by systemic hypercoagulability, thrombosis in the cavernous sinus is frequently triggered by local infections. A Staphylococcus aureus furuncle on the face, or a severe bout of sinusitis, can easily spread into this space. This diagram illustrates the cavernous sinus. An expanding clot compresses cranial nerve 6, causing lateral gaze palsy. Expanding pressure then hits nerves 3, 4, V1, and V2, causing ptosis and facial pain. Notice V3, the mandibular branch. It explicitly travels outside the sinus. If a patient presents with sensory symptoms in their lower face, the lesion extends beyond or is located outside of an isolated cavernous sinus thrombosis. Physically, the most pathognomonic sign of this specific thrombosis is extreme eye swelling, chemosis, and proptosis. The severe swelling begins entirely unilaterally on one side, but it rapidly spreads to engulf the opposite eye within 24 to 48 hours. This rapid spread happens precisely because of the intercavernous sinuses, which connect the left and right sides across the midline, allowing pressure and infection to freely cross over. Every symptom of cavernous sinus thrombosis maps directly to the neurovascular geography of the skull base, dictated entirely by the sinus's internal structure. Clinical suspicion is triggered by the profile, a hypercoagulable patient presenting with papilledema and neurological signs that don't neatly map to a single arterial territory. The initial diagnostic algorithm starts with D-diger blood tests and baseline imaging. Plain CT and MRI scans are often normal or only show secondary edema. To actually visualize the filling defect, the patient must advance to contrast-enhanced imaging or venography. Once confirmed, physicians face a major therapeutic paradox, prescribing aggressive blood thinners to a patient who has high-pressure venous bleeding occurring in their brain. Despite the presence of intracranial hemorrhage, the definitive medical management for CVT relies on immediate anticoagulation. The strict protocol begins with full-dose heparin to halt the clotting cascade, eventually bridging the patient over to long-term warfarin therapy. The physiological logic holds up. By stopping the clot from propagating, the valveless venous system can finally utilize its collateral channels to drain the fatal backlog of pressure, which actually stops the hemorrhaging. In severe cases, dexamethasone may be added specifically to reduce the mass effect of cerebral edema, while invasive surgery or shunts are strictly reserved for patients suffering from impending brainstem herniation. By recognizing the epidemiological profile of venous clotting and trusting the mechanical rules of a valveless pressure system, a clinician can safely execute a counterintuitive treatment that saves the patient's brain.